Swayam Prabha. Digital India. Educated India.
So let's go on to the next topic today, which is healthcare analytics. So we've talked a lot about it. So I want to put it in perspective what a healthcare analytics is. And I want to put it in perspective on the three levels, the macro, the macro, the meso, and the micro level. How integrating each of these, the micro with the meso with the macro, helps you develop even better systems. Give some examples in the India-specific applications. There's a lot going on in this country from a government level, from technology level, so we want to just understand some of these. And also at the same time, there are some trends, challenges, and emerging opportunities as we go through this. All right, so healthcare analytics, that what we want to call it as a multi-lensed approach to improving health outcomes. So I'm going to divide it into three parts. Part 1 at the healthcare level, Part 2 healthcare supply chain level, Part 3 healthcare supply chain India level. So that's the three type of things I'm going to. So I'm going to repeat some of these slides, but with the data and information to each of those three types. So a deep dive into the macro, meso, and micro perspectives of healthcare analytics reveals it's a powerful framework for driving improvements across the entire healthcare ecosystem. So from shaping national health policies to personalizing patient care. So that's the range at which you see macro to micro. Understanding these distinct yet interconnected levels, none of these are operating in a vacuum, is crucial for looking at how data and healthcare can interact. So I already talked about this. I'm going to talk about it at the healthcare level and then supply chain level, and after that at the Indian level. So macro level, this is the overall healthcare, 30,000 foot view of population health. So what is macro level healthcare analytics? It focuses on entire populations. So we're not interested in just one particular patient level, the population level. So what are some of the large scale trends? How does that inform the public health policy and how to allocate resources more effectively? So these are at various levels, but here example is, as I said, non-communicable diseases are the number one issue in many parts of the world. They are the number one here in India, which includes at least two major ones. One is the diabetes, the other one is heart or cardiovascular kind of related issues. So understand, but it doesn't play out the same way everywhere, right? Population, geography, age, male versus female gender, all those things influence what you understand. So depending on that, the allocation of resources will be impacted. So what are the key characteristics if you think about it? Of course, population health, the epidemiology, what are the health economics, and what kind of a health surveillance do you do? Government does it every year. They have National Institute for Health here trying to survey and understand the population level statistics. So the data sources are national health surveys, census data, vital statistics, insurance claims databases, and data from international health organizations like WHO. This is at a global level I'm talking, not at the India level, just global level. If you want to understand population health, these are the type of things people look into. Analytical methods here are biostatistics mostly, epidemiological modeling, which is how does disease progress within a particular community and so on and so forth. Geographic information systems for mapping disease prevalence, and comparative effectiveness research. How does a particular drug work with a type of population kind of studies. The key stakeholders here are mostly government agencies, right? Centers for Disease Control and Prevention in the US, National Institutes for Health, policymakers, public health organizations, and international health bodies. All those are interested in understanding what happens at a population level type of health outcomes. So what was a real world application? Keeping intact with the COVID that happened, the macro level analytics were indispensable. Governments and public health officials relied on real time data on case numbers, right? Hospitalizations and deaths to track the spread of the virus, identify high risk populations, and implement targeted interventions such as lockdowns and vaccination campaigns. So they did not happen in a vacuum. They happened because the data was coming in and they were looking at it. This data also informed resource allocation, ensuring that hospitals in hotspots received necessary supplies and personnel. We heard a lot of stories about how nurses worked 24 hours. They would come out because of safety. They had to be boarded in a different hotel or whatever it is, isolated, then brought back again. So all these logistics aspects that happened around that time is what we are talking about. So questions, comments on macro level, looking at population health. Please, you. Why don't you do the honor for me?
Introduce myself.
Yeah, please do. Please do.
So I'm Raja Gauri. I'm doing Master of Hospital Administration now, final year in CMC. So, sir, I understood, but I have one doubt. So, how does a geographic information system happens, and how does the information just getting shared among the different cities and states?
I mean, most of the times it is the government entities that have these kind of resources.
Good question.
So the government, in this local state government, if it's a state government, or National Institute of Health, they do maintain data. It's a database. GIS is a database, right? It will put all the zip codes or pin codes and things like that, and look at information coming from that in terms of this particular pin code has these number of cases reported. Then their responsibility is to feed it into this and provide that information live to people who want to log on and look at it. And mostly it will be hospital administrators and others. So many countries have that. Again, they could start at the central level and then move on. And some decentralization happens at the state level also. Yeah.
So, I'm Shweta and I'm doing my Masters in Hospital Administration, final year from CMC. So, ma'am, as she told that how it is passing, but it is a confidential thing also. Like, let's say, what is the thing that they have to show their data? Like, this is mandatory that they have to show, but everything they can't just show it online or accessible to everyone. So, how they are differentiating that this they have to show and this they can, they can keep it for their personal use?
Yeah, I think very important question, very good one. So, looking at the macro level, when a population statistic is reported, you are lucky. You are not talking about Shweta separately. But when you go to patient level data, then you have a lot of those privacy issues that you got to be careful. So that goes with the country, the region. What is privacy to the patient? What's the patient code of privacy? So that's very important on what you can release. When Professor Sundar yesterday, when he talked about Atlanta, he was not talking about Shweta's name there on the board. They're talking about a bed number and when that bed will be available, kind of information for people to see. To some extent, some of these also creates that competition. If I'm not doing my job well and my bed is occupied for a longer period of time, how do I help the hospital to get? But so you have to be extremely cautious that patient information cannot be displayed or disclosed. Financial terms, no, finances will never be, nobody is going to report any finances of the hospitals in these kind of systems. Not on a public display. Let me go to the next slide and then we'll call upon others to talk. But thank you both. Good questions. So we'll talk about meso level next. So we did talk about macro, we're talking about meso. So narrows the focus to organizational or community level. So when all the way from macro, which is national level, we come down to a particular organization or particular community level, encompassing hospitals, health systems, insurance providers, and regional health authorities. The objective at this level is to improve operational efficiency. Remember, the objective at the previous level is large-scale trends, inform public policy, allocate resources effectively. So that's what at the macro level was. At the meso level, you're talking about operational efficiency, enhance the quality of care delivered, and how do you manage costs effectively. So those now come down. We won't be reporting finances, but it may not be wrong to talk about costs, because that is something we all have to manage. And it'll be good to know if somebody is doing two different tasks and one is doing at twice the cost and then the other, knowing that helps to see how I can reduce my costs. So from a cost level, it's important. What are the key characteristics of the meso level operations? So the focus is hospital administration, operational efficiency, quality improvement, and financial management. The data sources here could become local. Now these are the electronic health records, hospital administrative data, which is admissions, discharges, transfers, patient satisfaction surveys, and financial records. The analytical methods are mostly the predictive analytics for patient flow and resource planning. So one of the big things, I think later on I'll show an example, is the discharge time. We talked yesterday about when does a patient get discharged? How can you predict the discharge time of patients? Because knowing that helps allocate resources to get that done and predicting when the bed is available for the next patient. Key stakeholders here are mostly hospital executives, clinical department heads, quality improvement teams, and healthcare administrations. Quality improvement teams. So, about 25 years back, probably, United States published a metric called door to balloon. Anybody knows what that metric stands for? Door to balloon. This metric stands for a heart attack patient when brought in to a ER, from the time they come in through the door to the time a stent with a balloon is inserted, what the time should be. Because these are the most critical patients. So they gave this metric. Actually, they challenged hospitals with a metric that says door to balloon metric. And hospitals had to comply to this. So hospitals started all kinds of innovation around this. One of the innovation is, how do you train the ambulance operator to stabilize a patient? So when you look at a supply chain, in this particular case, the supply chain starts with who is picking up the patient and the patient coming to a hospital. And finally, the intervention in the hospital. So mapping this process of supply chain, then you think about, initially you would think about, okay, I'm going to look at this process. Patient has come in. I need all the doctors. I need all the things to happen. But patients might have reached a stage that you cannot do that within the time allotted. Whereas, can you stabilize? So people start thinking when the process gets a little longer and what the support processes are. So quality improvement teams are the ones that led that project in the US at that time. Real world application. By analyzing EHR data, that is electronic health records, they can identify patients at high risk for readmission. This is another big deal. Do you know, in India right now the statistic is that Karnataka and Arunachal Pradesh are the two states where the readmission rates are only 1%. And some parts, which I will not mention, the readmission rates are greater than 11% average. So you got to look at why. Some places the patient population is small. So let's take that. But the readmission, everybody understands what a readmission is. Patient has been discharged. For whatever reason, they have to be brought back. For the same kind of illness or treatment, they are brought back into the hospital. So Google it. I was Googling it last night saying, what's the readmission rates are there in India? And it was interesting to see the states-wise data show up. Now, I don't know the authenticity of this data, so take it with a pinch of salt, but at least it said something interesting. This is not only improved. So, if you can identify why that happens, why readmission happens, many of the time, post something, patients don't take care of themselves well. That's a primary reason for readmission. So, if you could have social workers visiting patients and helping them to take care, that intervention research-wise has shown that would reduce the readmission rates. So, that post-discharge follow-up calls or home health visits. This not only improves patient outcomes but also reduces the financial penalties, because if you report to the government funds part of the hospital systems, readmission rates is like a penalty. If they exceed certain rate, it's a penalty to the hospital. Hospitals might lose funding. So that's why this is. So that's a meso level. Meso is at an operations at a hospital level. The analytics are used to improving the overall health of the patient, and this is one example of it.
Hello sir, I'm Minma Victoria. I'm pursuing PGDHA from CMC. Thank you for this. I understand a lot of things from meso level, so it will be helpful in the day-to-day operations of a hospital, whether a hospital administrator can decide those things, and to many of them administrator can involve in to discuss about that reduce patient readmission rate. Thank you.
Do you interact with healthcare systems, computer systems that gives data?
You're asking me?
No.
No, sir.
Okay. Someday you will.
I'm Savita. I'm pursuing PGDHA. I'm from CMC.
Big contingency from CMC. Go ahead. Sorry. Go ahead. What are your thoughts? You don't have to have a question. We are just trying to understand. We've been talking here for 3 days. What?
Actually, I have one subject in materials, supply chain management. I learned and I understand this.
So the
Yeah.
talk about risk really. So
Like quality management and financials management.
What in quality management are you learning, please? Can you tell me?
Patients satisfaction
Okay.
and improving the waiting delay, and that's the quality management.
the context, like without the So what is your
Yes, sir. The gentleman there.
Right.
Must.
So myself Alfred. So again, I am from CMC doing my masters in hospital administration. We are doing a final year, so we are into the projects. So we are given a chance to select the topics on any field. Let's say even in operation, one of our classmates is doing a project on supply chain, like the inventory system. So this we can relate it. We are not into the working aspect, but then we are studying, so we can try to able to we try to able to apply what our educational, like what we learn, we try to understand, but operationally we cannot understand much on these elements, but it will be useful in future, I suppose, because we get to listen a lot of real time experiences from the expertise over here, and also certain elements are new for us, let's say the blockchain, even the digital twin. So obviously yes, and coming to this aspect of operational level, so we are involved in lot of elements in this, so we do get the postings in the areas, So that is where we exactly learn all these elements. Like maybe they are freshers. I think they'll get into this postings and all. Further which I think they're able to choose the topics also. So it'll be more useful for them. And then I am doing my project on different thing.
What are you doing?
Mine in the engineering services, the compliance rate engineering services. Yeah. Thanks.
Thank you. Let's go to the next level, which is the micro level, right? I did not, that's it's an easy one. I mean, somebody understood what readmission rates are, so so that's all.
And they are also important KPIs.
Yeah. I mean, quality, patient satisfaction survey somebody talked about. Readmission rates will mess up your patient satisfaction.
So practically, so you would be aware, most hospitals do not divulge these kind of details. And even if someone is interested in measuring such indicators, they do not give access unless the hospital itself decides that it should have a measurement.
Yeah.
Otherwise, it's only length of stay, bed occupancy, and discharges, admissions, and if they're good, hospital infection rate.
Yeah. I mean, they may not disclose it to public like you and me. Hope they do, but they don't. But either they are funded by somebody, mostly by the government. So they have to report some of the statistics to the government. So somebody has to question it sometimes if continuously a KPI like readmission rates are higher on the average than the regional average there or other hospitals. That's something to think about. For example, hospital acquired infections. That used to be so high in the 70s and 80s that hospitals took a lot of efforts to bring it down because unnecessarily they were losing patients, not because of treatment issues or the condition of the disease, but the hospital acquired infections. So, unless they tracked it and understood what it was, efforts would not have been done to change it. So, it's important. There's nothing shameful about these things because you have to understand why this is happening as opposed to it is happening. So, micro level represents, of course, the most granular, right? So, we started with macro, meso, now we come to the micro, and we are talking about healthcare analytics, which means how do you take data on those kind of issues and how do you look through it? How do you see any patterns? What do you learn from it? Can you use that to predict? Can you use that to understand some overall statistics? This is what healthcare analytics is. And you could put all kind of sophistication into it, blockchain or, AI and all, but basically you need good data. And at the micro level, you are talking about, personalized medicine, provide clinical decision support to healthcare providers, to empower patients to take an active role in their own health. Example is active role in your own health. So if I shared this already, stop me. My operation ended 5 hours later. So I was in bed at 7:30 a.m. Around 12:30 p.m., the operation ended. My anesthesia wore out around 7 p.m. 11 p.m. that night, they made me walk from open heart surgery. And it was critical that kind of an empowerment they made me ask for it to walk. And then every day, next 2-3 days, they made me walk almost 3 to 4 hours a day. So that kind of an empowerment, unless a patient wants to take and use it, will not help in the recovery process. So what are some of the key characteristics of this? The focus is on the individual patient outcomes. Could be personalized medicine, clinical decision support, and patient engagement. How do you engage the patient? Patient is a critical part to engaging the patient in recovery. So we take a look at the individual electronic health record data, any genomic and proteomic kind of data from wearable devices if you want to collect some data, and patient reported outcomes. One of the biggest outcomes is you think when you go through these surgeries that you don't have any allergies. and you are exposed to all kinds of medications, and you will find out some of those will create allergies. So that's what is a patient-reported outcome could be. The analytical methods here are, we're going to talk about this tomorrow too, about machine learning, natural language processing to extract insights from a clinical notes, and real-time alerting systems. So the key stakeholders here are clinicians, physicians, nurse, patients, and other caregivers. What's a real-world application? Let's look at an interesting one in diabetes. Micro-level analytics can be transformative. A continuous glucose monitor can stream data to a smartphone app that uses machine learning to predict hypoglycemic events and allowing the patient to take preventive action. So if that comes through and warning through your phone, it'll be interesting. This data can also be shared with the endocrinologist, who can use it to tailor insulin dosages and provide more personalized advice. These are actually happening. These are not made up examples today. And a lot of this is not out of reach of any country. With the smartphones and wearable devices and things like that, they are available. So low-cost solutions to some extent, we want to think about it.
Yeah, hello sir. I am Sivaranjani. I am PGDH in hospital administration, CMC student. And then it is new to, I studied in college, I think, in supply chain management. I have more deeply knowing many concept of supply chain management here. I have learned many new terms that supply chain and resilience. I have new to that, and I just try to understand.
Good. Thank you.
Thank you.
Anybody else? Okay. When do we stop? You let me know. Okay. 5 minutes? Okay. Okay. So we have now covered at, macro, meso, micro at the healthcare level. Now, if you take the same and put it at supply chain level, what does macro mean in supply chain, meso mean, and micro mean? That's what we're going to do. Oh, sorry. Before that, how do you kind of use that information from all three levels? That's important. Micro can feed into meso, meso can feed into macro. So that is another powerful way of using the data analytics and let's look at that. The true power of healthcare analytics lies in the seamless integration and feedback loops between the three levels. So what feedback can each one give to the other? Insights generated at one level can inform actions and decisions at the others, creating a learning health system, a system that learns and continuously improves. For example, micro-level data on effectiveness of a new cancer treatment across thousands of individual patients can be aggregated at the meso level to inform hospitals' clinical guidelines. So if you look at CMC as an example, if you look at clinical guidelines, they constantly go through scrutiny and change when something new happens. New happening does not happen at a huge patient level. It will happen at individual patient level. And that data feeds in to inform at a hospital clinical level. How do you do that? And then they'll become national. If a CMC type hospital would do that, that informs other hospitals that they have started doing something significant, and other hospitals will pay attention. And I'm sure CMC doctors and others present in conferences, that's another way of disseminating this information and data. And so others will listen, they will start doing it, then the government starts mandating it, that this has to be a protocol. So that's how some of the protocol treatments and approaches that you see. So it starts at the micro, goes to the meso, and then macro levels. So what are some of the challenges if you look at this whole area of healthcare analytics at the healthcare level? Data silos. A lot of data is there, but they are all siloed, which means they reside within a computer system, or as people said, they have privacy type of issues that cannot be shared. So it cannot be used sometimes. So that becomes a problem. That was the second one. So data silos is where data is not shared. Data privacy and security is, it's a sensitive data. It cannot be given out. It affects not just the patient, but the patient population from insurance and other kinds of things. So, and in the US, it's the HIPAA Act, right? So it's a Privacy Act that prohibits what you can report, what you can share with others. Workforce skills. There is still a shortage of healthcare professionals with necessary data science and analytical skills. Hopefully, as you guys go through this, it is no longer, some computer science nerd sitting behind a computer trying to manipulate. It has become so easy. I'll give you a quick example. I had a secretary who used to manage travel for me. Well, this happened quite some time ago. And she became very good with spreadsheets, right? So she learned it on her own. She would create, analysis for me and all. So slowly I started kind of instigating her, saying, how do we reduce the cost of travel? We had a lot of variables. She would tell me, if these professors would register on time, then they don't have to pay the expensive rates. She will give me this. So I said, why don't you go find out who did what on time? So she will come up and with a printout for me saying, these 3 professors did on time, these 5 professors registered late, so they each paid $30 more for registration. Same thing with cancellation of flights. And all those type of... She started really getting into analysis of the data that was collected because of somebody traveling and reporting it and had to get reimbursed. A mundane data. Nobody wanted to look at it. She made it so interesting for me that I used to put this as a record of shame to my faculty. I won't name anybody, but said, if everybody booked on time, the department would have saved X amount of dollars. You're going to the conference anyway. Why are you lethargic in not booking on time? And then slowly this became now the secretaries or others' jobs to make sure they nudge and book on time. So, long story short, she left me right away. She got a better job because I trained her to be a data analyst. So, I lost a good person, but good for her. But I'm telling you, this is an area, wherever you study, whatever you do, is something to think about. Is what is data that you're going to encounter and what are the basic analytic tools that you could use to do that. I think we'll stop there.